All right, good evening, everyone who's able to attend live. Thank you so much for taking time out of your evenings, out of your afternoon, to join us for our live town hall series. And if you do have to leave early, or if something happens with your connection, we are recording this, and so we will be able to post this on our website, on YouTube, and make sure that the entire content is available. So the objective that Laura Richardson and I have for this particular town hall is to address some of the questions that were raised after we had posted the virtual town hall. And what we'll end up doing is use the first portion of this hour to address some of those questions, and then we'll open it up for questions at the end. Everyone's settings right now is set so that you would be able to send a direct message to the hosts and the co-hosts of this presentation. And so we'll be able to track those, organize them, and answer those questions at the end. Before we get started and answer some of the questions that have come up, I'd like to emphasize a few things that are coming up with Clinical Exercise Physiology Association, but take some time to, again, encourage individuals who are in the profession, whether it's academia or it's applied, and to become a Clinical Exercise Physiology Association member. You know, this is one thing that really benefits not only the organization, but the members and the profession. One of the biggest hurdles that we have right now in professionalization is really demonstrating the size of our professional group, and how we've really been significant players in the clinical space. So you would be doing a fantastic service to the profession, the members, and the organization if you take time to use this QR code to go to our membership website and look into the different membership options and become a member or renew your membership if it has lapsed. Next, I'd like to promote some things that will be coming up with CEPA. We're going to be having our annual conference February 11th. We have a pretty impressive bunch of keynote speakers. I think everyone on this call can certainly recognize 2 to 3, if not all, the presenters here on this slide. Additionally, for the first time, we've opened it up to session proposals where we have experts within the clinical exercise physiology field giving talks on their particular area of specialty, as well as the profession of clinical exercise physiology. In addition to abstracts that have been submitted, scientific abstracts with the opportunity for early career investigators to win a cash prize, an award for presenting the best abstract and e-poster. So I encourage everyone to register for the virtual conference as well. In March, we're going to be having a webinar on exercise and rehabilitation in individuals with kidney failure, challenging the status quo. An expert within the field, Dr. Ken Willand, is going to be giving this talk. And this is a topic area that I personally don't think is addressed often and effectively. And Ken is truly a leader within the field and is doing some pretty impressive work at the University of Illinois Urbana-Champaign. So please also take the time to register for this very important webinar. And then our last announcement is that we are revamping and growing our clinical internship directory. Right now, we have it open within our website where if you are in a clinical space that offers internships, you have the opportunity to register and list internship opportunities that are available in your clinic, in addition to details that would help students identify which internships they would like to pursue. Right now, the application window is open, and at late February, we're going to be launching this directory so that students and individuals looking to gain experience in clinical exercise physiology would be able to benefit. Today, the main topics that we'll be addressing and answering questions from the previous recorded town hall are related to programmatic accreditation, changes to post-nominal titles, NPI numbers, the topic of licensure and what that means, future of the profession, as well as the CEPA fellowship program. Now we'll move on and we'll start the session with programmatic accreditation, which will be Laura Richardson will be able to give us information on.
Yeah, thanks, Cemal. So we've received some great questions, and we hope to get more this evening on this live town hall. But starting here, we have some great input that talks about being recognized as a QHP provider. We know that they've heard and listened to the first town hall, but why are there so few programs that have currently been accredited? So I just want to reply and let all of us know that we understand that we're following the trajectory of other allied health professions that have gone before us. We have to start somewhere. We also have to recognize that this accreditation process, getting programmatic accreditation, is pretty much non-negotiable for any institution that really wants to help prepare students for career readiness. So again, it's a slow process, but we are beginning this. All of our other QHPs as well come from accredited programs documenting curriculum that aligns with industry standards. So this process really provides the backbone to all professions. So as we in exercise science begin this journey to get to programmatic accreditation, we're really ensuring that our students are adequately prepared for the profession. We are helping us to become recognized within the healthcare community. And this widespread accreditation will ensure greater consistency between exercise science programs, obviously helping to document outcomes, to adequately prepare our students. So we know that there's more coming. As we take a look at it, programmatic, as this diagram documents, we know currently things have a lot of variability across the nation. We recognize that the accreditation process, again, is going to help to set that bar and provide that minimum threshold for competencies for students to be prepared. So as we're looking at this variability, we know that some schools may have some tough conversations and faculty meetings about how to progress with accreditation, with some schools really being focused on research and others doing a combination of research and helping students earn and acquire those applied skills. So we really just want faculty to be cognizant of the importance that programmatic accreditation helps students to come out of that program prepared for credential to be practicing in industry. And I just want to pause here as we take a look at as faculty across the nation may be contemplating this, that when we take a look at salary, we don't want to lose sight to what the salary is for a bachelor prepared student versus somebody who's in academia, maybe, earning faculty salary with a PhD. There really is a vast difference in salary. We have that data in our most recent salary survey, these differences, and we really hope that faculty and academic programs are remembering that we're hoping to get students prepared for the credential and earn the highest salary they can. And we know that highest salary within the field of exercise science comes from those with a credential, with a certification, and giving them the skills that they need to, enter clinics, industry, wherever that may be. So we really hope that helps with that current state of thinking through, making that decision to apply. So as we take a look at where we stand right now, again, as the transition is happening and people are submitting to KHAP that request for accreditation service, the first step towards becoming accredited, we expect that volume to begin to increase. Currently, as we stand today, there are 99 accredited undergraduate programs in the nation, 14 at the graduate level, 7 at the applied. And in the process, those that once programs have been submitted, they are now provided a self-study. So they're, in the trenches of really getting that process going. And we have 45 that are in that state right now and 9 undergoing site visits. So we're making some progress. So that's good news to share with you. As we move forward, again, I want to just kind of let everyone know, we know the process is slow. This is aligning with those that have gone before us with in the healthcare field. The Committee on Accreditation for Exercise Sciences, again, has set the date for 2027 for the nationwide programmatic accreditation date. Again, we recognize only a small handful, as of today, more than a small handful have completed the process. But we also recognize that nationwide, most institutions are teaching very very impressive curriculum. And for most, it should be a smooth transition to fulfill programmatic accreditation. We do predict, again, as the date becomes closer, the numbers are going to climb and volume is going to, again, align with other accredited healthcare, physical therapy, nursing, all of those that have gone before us. We're beginning that process and we're proud of where we're at today. So before we move on, any questions?
Nothing yet, Laura, no, Sue?
Okay, that's great. Okay, we'll turn it over to you, Cemal. Thanks.
Great. Okay. All right. So this is something that I like to speak openly about, frankly about, because it's a very important topic, and I'm very glad that someone posed this question related to the post-nominal titles. Question reads, when I was accepted into the Registry of Clinical Exercise Physiologists back in January 2019, I received a letter that stated, we encourage you to promote your inclusion in the registry by denoting ACSM after your name and degree. Now I'm being directed not to use that and go back to ACSM-CEP. This is how I sign all my patient notes, and to change that now makes me concerned. I fear it is this variability and incongruity that makes us look unorganized and indecisive as a profession. And I think this is a topic that we all need to recognize, that there has been a lot of confusion when it comes to post-nominal titles, different registry, the different certifications, the different exams, all the changes that have happened over the years. And I think it's important to step back and really appreciate, indeed, yes, this has been a very complex scenario. So if we start back in the 1970s, the first certification available was for program directors, and it was closely followed by exercise specialists. Right around 1998, the beta version of the Registered Clinical Exercise Physiologist, or the RCEP, was introduced, with exams being available around 1999. In the early 2000s, exercise specialists changed to clinical exercise specialist. 2013 to 2014, clinical exercise specialist was renamed to clinical exercise physiologist. And then the health fitness instructor was changed to health fitness specialist, which was then renamed to exercise physiologist. 2018, the RCEP was retired, and the ACSM-CEP exam and the criteria to sit for that was modified so that there was a kind of a mixture of some of the criteria for the RCEP, some of the criteria for the CEP or CEP exam. And quickly after this announcement was made, a number of individuals were rightfully a little angry and confused and a little frustrated about this change, primarily because the exam for the RCEP was very challenging. It was a tough exam to pass, and it was a rite of passage for individuals that were able to sit for the exam, study hard for it, and pass it. And we've heard through many of our communications and connections with our members that this was something that was tough to swallow. So in response, CEPA created the registry for those individuals that had passed and had the RCEP exam. Well, recently, 2022, 2023, we're effectively discontinuing the CEPA registry. And this was reviewed in depth in the recorded town hall. But the primary reason for this is to really get back to the purpose of a registry and to clarify a number of questions when it comes to applying for QHP status. And in the context of when we say registry, this is a database that is housed of individuals that have passed a certification or a board exam and are in good standing to practice within that field. The CEPA registry didn't fully accomplish that. It was a registry that really had the site of recognizing those individuals who had passed the RCEP, individuals who had then subsequently passed and taken the CEP exam and are working clinically, So we wanted to discontinue this and find a separate path that really helped individuals still maintain recognition for their service in the field, the profession, their institutions. And we will be replacing that with the fellowship program. And our intentions are to open up applications during the ACSM annual meeting. And more information about criteria will come as our committee develops those criteria and publishes those. Now, when we look at this timeline, there are a number of changes, and it's easy to understand why there is a lot of frustration around many of these changes. It's also important to recognize that with each one of these subsequent changes, it was a step forward to where we are today. All these changes were intended to increase the quality of professionals entering into clinical spaces and to ensure that our graduates are getting the right training, are passing the exams to really demonstrate that they possess the skills to work effectively within the organizations. And the major thing that was missing prior to current efforts was a central focus or a central goal that really tied everything together, that solidified the titles that we use and the certification exams that we take to demonstrate qualification. And really the clarity is starting to emerge, and things are starting to crystallize on the titles that we would use and how we would go about this. And this is largely due to the ACSM task force, ACSM leadership, and individuals that are recognizing the importance of creating a roadmap, of starting to build this plan, of coming in organized, having our ACSM-CEP board certification. So now that is referred to as a board certification. And these volunteers and individuals are truly leading the way in these task force efforts. Our past president, Trent Hargens, had been serving on the task force, and now we're introducing a position for the current CEPA president or immediate past president to continue to contribute to this effort. And so now that we're in this spot that we have clear delineation of the path we need to go, the certification, the board certification we need, as well as post-nominal titles and how we should refer to ourselves, this is really going to start to become more consistent and be sustainable without these major changes that have happened in the past for good reasons, of course. And to reiterate, the other major contribution and change that has been included is that individuals who pass the RCEP, who pass the ACSM-CEP board certification, should refer to themselves as registered clinical exercise physiologists below their name, and have a hyperlink to the US reps where they are housed as that professional. So while yes, there has been a lot of not a lot of clarity in the past, as I mentioned, now things are starting to fall into place, much more clarity, and this is going to only continue and establish ourselves as clinical professionals and will contribute to QHP efforts. With the interest of time, what I'd like to do is to continue going through the slides and then have an opportunity at the end of the presentation to address many of the questions that will likely emerge from these topics.
Thanks, Cemal. So I'm going to move into the National Provider Identification Number. So we have gotten some questions after the first town hall about this, some confusion about the EP and the CEP. So I want to say, our focus is on really the CEP and blazing a trail to advocate for our profession. But I really think it's important to provide some clarity. So for those exercise physiologists, both EPs and CEPs that are practicing in clinical settings, we do encourage you to obtain a National Provider Identification Number. So to help give a little background, according to the Center for Medicare and Medicaid Services, any of our healthcare provider who's using electronically transmitted health information to connect within HIPAA needs to have an MPI. So if you're an exercise physiologist, again, an EP or CEP working within the provider that is, under the HIPAA, documenting patient care, then we want you to follow these steps to register. So the taxonomy code is going to be the same for both certifications that are practicing. So I think that's an important thing to say, right? So the billing for clinical exercise is billed by the facility and not by the individual person. So the application steps are really pretty simple and require you to make sure you provide your primary practice location, so the address, phone, email of who you're working for within. There's a lot more detailed information here. We've got the photo here of the article written by Dr. Paul Gallo and his group on the steps to register for the MPI. So I really hope that helps to give us some clarity. So another question we have, similar question is, once we obtain the MPI, on the next slide, Cemal, once we obtain this MPI, what does it do for us? So letting us know as a collective group of all of us here on this call and those that are watching this in the future, when you get that MPI number, it provides a quantifiable measure of the number of practicing professionals in our field. And that's a really important thing as we gain momentum. Obtaining your MPI number documents the volume of providers practicing in a service, and it provides really pivotal recognition for the profession through organizations such as the American Medical Association and others, to eventually get us recognized as qualified healthcare providers. And again, this is helping us. We're following along with those allied healthcare providers that have gone before us in programmatic accreditation and being recognized as a provider. So again, if you're practicing with either of those credentials, I think that's clear because we're most focused on the CEP, but I want to pull in the EP here because we recognize there are many EPs working in clinical settings, that the MPI is free and for you. So again, take a look at some of the links we provided in our previous town hall to help guide you through that.
Okay, now moving on to the hot topic of licensure. So this has been around, and this conversation has been around for a while. And I think it's important to clarify what licensure means. So the question that was posed was very simple, but of course it's a major topic. So future of licensure for CEPs. Right? Key things I really want to emphasize on this slide is the purpose of licensure. So the main purpose is to protect the health, safety, and welfare of the consumer and not the professional. So this implies that there is enough intrinsic risk that practicing CEP needs to be regulated. Now, when we're looking at areas where CEPs are currently practicing, we do not practice in a manner that is similar to, let's say, a nurse or a physical therapist, where they have direct one-on-one contact with individuals. With a clinical exercise physiologist, in many cases, they're working in let's say a service line, cardiac rehab, pulmonary rehab, where you have nurses, other clinical exercise physiologists, you have safeguards where you have physician supervision and a team of experts that are able to maintain safety for that particular individual. So what becomes complex in the current state is that how do you differentiate and how do you identify that in this cardiac rehab program, that clinical exercise physiologists need to be licensed. There isn't any type of innate risk that is evident, at least right now, that is demonstrating that some CEPs just don't practice as safely as others, right? Additionally, exercise in individuals that are being appropriately medically managed is extremely safe. The idea of licensure is really going to come up whenever we do achieve the ability to be reimbursed for our services, work one-on-one with patients, and to really collect data and information to see if there are intrinsic risks with working with a clinical exercise physiologist, and is it necessary to move towards licensure to ensure and protect the health and safety and welfare of that consumer. It's designed to limit the number of people in practice. And this means that we have a defined scope of practice stating what we can and cannot do. So this is under the premise of licensure. This is a law that says, as a licensed professional, this is your scope of practice, and this is what you are able to do and not able to do. We currently, as clinical exercise physiologists, do not have a scope of practice. Because this is such a readily utilized term, there may be presentations, conversations with colleagues, experts within CEP that may use scope of practice because it is universally understood that you're describing what that professional does. I'd like to emphasize that for clinical exercise physiology, we do not have a scope of practice. And with many of the publications that we will be publishing in the Journal of Clinical Exercise Physiology, we're going to be referring to it as practice patterns of clinical exercise physiologists within different clinical spaces. Practice patterns within cardiac rehab, practice patterns within pulmonary rehab, and not using the term scope of practice. When professionalization occurs and legalization of that determines who can practice and who cannot, this is when a scope of practice can be designed and may be implemented. So only those individuals meeting the set requirements to practice as the identified professional may provide services within that scope of practice, that legal statement that gives you that privilege to be able to provide that specific service. Now, very little, if any, evidence of less than qualified practitioners causing many injuries. So right now, we just don't have that data. And we've done an extensive search in the past when licensure was the main topic at hand. But we, through this process, are able to understand that in order to be reimbursed, you don't have to be licensed. Many of the professionals that have come before us to become QHPs and get billed for their services or reimbursed for their services didn't start off licensed. It was not until later that happened. Now, will CEPs be licensed in the future? We don't know. Maybe, maybe not, but that is not the primary focus right now. The primary focus is being recognized as qualified healthcare professionals, providers, and then have the ability to bill for our services. And that is really going to open the floodgates for our ability to practice within this field and deserve the respect and autonomy that we've been searching for a long time. Okay. Let's see. As far as certification, it will be imperative to establish a pressing need to demand for CEPs in healthcare. Most healthcare settings do not require certification for employment as EP or CEP. And Laura, is this your slide or is this my slide?
I'll hop on. I don't remember. Look at that. So when we think about professional certification and this question we got, I think it's important that, you know, once we're recognized as QHPs and as the field begins to grow, being reimbursed for our services, you know, I'm certain that more of these certifications, you know, the question of what happens and what's going to come forward will, you know, begin to grow. I think that's an important thing. I think with billing codes and CPT codes, again, all of these are in our, I would say, graspable future. They're not too far down the road. And we have ongoing occupational research with documenting our skills that we're going, you know, the prevalence of chronic disease and how the CEP can help fill that impact on serving patients is, I think, going to help with recognizing what certifications can serve us well. What am I missing on this one, Cemal?
Yeah, I mean, that's spot on. I mean, a lot of the efforts that are being done by the subcommittees of the task force are accumulating this information. And that's going to be imperative to our ability to truly demonstrate where we practice, how we practice, the benefits that are associated with it. And yeah, when it comes to certification, when we're looking at clinical spaces, you don't have to, technically, you don't have to have ACSM-EP or CEP to practice within cardiac rehab, pulmonary rehab. And it's when employers hear that we will be able to bill for our services, and it's the requirement will be you pass the board certification, ACSM-CEP, you can be reimbursed for your services. And when employers hear this and you start to put the financials together and the ability to generate revenue, that's when certification is going to be required. And that's when this will be something that becomes more formalized.
Right. And I think it's important to also state that, when we take a look at what skills we do, not everyone understands the skills and abilities that the CEP has. So there are some upcoming publications. We'll be sure to share those with you. That is documenting the beginning of documenting what those unique skills are we have. And as more physicians and other, extenders within the healthcare field recognize what we can provide in a multidisciplinary team, I think you're going to see more and more human resources wanting exercise for professionals to have our certification. So I think there's just a lot of momentum on its way.
Mm-hmm. And just for the record, I think we should be pushing these employers and clinical settings to hire certified EPs and CEPs to really start that practice of recognizing what it takes to be an effective practitioner. So we shouldn't wait until we get QHP status, we get reimbursement to start implementing this. This should happen today. That's going to help increase our recognition in our place within the clinical spectrum. Let me go to the next slide here.
So when we take a look at what the future holds, just kind of, springboarding off of what we just talked about, we really fully believe that what we're seeing in healthcare is a need for more exercise professionals to come to the table as both multidisciplinary and interdisciplinary team members. We recognize that within not just cardiac rehab and our typical cardiac pulmonary, but from oncology to bariatrics to so many extended chronic diseases in other fields, other professions, the future is only going to continue on this momentum of wanting. We realize that there is a nursing shortage. We realize we have a lot of skills and abilities that the CEP can provide in a lot of these settings, and we should continue to see the projection continue to increase, which is what the data is in our, our data that we see right now in our career outlook for the CEP. So, it's positive. And I think these questions that were submitted to us are legitimate. And I think, again, we don't need to have the certification, but it helps us to really get your colleagues, your coworkers to be hiring, new candidates that have that credential and beginning to have a advocate for ourselves within the healthcare field. And also note this infographic that's on this slide, just on an off topic here. This is a beautiful infographic. It's free and available on our website. So any faculty here that are teaching, clinicians that are working, please download and share. I think it's only going to help spread the word for what those skills are that are uniquely qualified skills that a CEP has that other healthcare providers don't have.
In regards to CEPA fellowship, one question that was posed was, how can student members get involved with the CEPA fellowship program? So typically, and this is how our fellowship program will work, is the fellowship status is reserved for professional members that have been active within the organization for a defined period of time and have contributed significantly to the organization, to the field, and just the general practice of clinical exercise physiology. So in this particular context, if you are a student member, the time that you are spending as a student member doesn't go towards the criteria that will be set for fellowship status. However, if you are a CEPA member, it significantly improves your ability to enter into your professional membership and accumulate the necessary experience as well as dedication to the organization and the field to make yourself a very viable candidate for fellow status. And an amazing and a great place to start is to contribute and volunteer to CEPA committees. We have a number of committees that have very passionate individuals that are pursuing goals within each one of these committees that have a specific focus in moving the profession forward, as well as the organization. The way in which you would identify if you are interested in being a part of these committees is going to our website, ACSM-CEPA.org, going to the About tab, going under CEPA Leadership, and towards the bottom, there's a form that you would be able to fill to express interest in being a part of committees and contributing to the expansion and growth of the field through the Clinical Exercise Physiology Association. So while that time doesn't necessarily contribute to the criteria that will be necessary to put in an application for fellowship, it is certainly time that is not wasted. It'll be time that we can certainly look at your application, see that you have extensive dedication and commitment to the organization, and it allows you to take more leadership roles once you become a professional member and once you're in the organization long enough. So I encourage all student members, if you haven't reached out, if you haven't looked to see what committees are available through CEPA, take the time to do that. And if there are particular areas that resonate with you, reach out and express that interest. We are always enthusiastic about professionals, students who are looking to become more involved in the organization, because that not only helps grow our offerings, it allows us to develop new leaders within the field. And this is going to work really well with our mentorship program that will also be released in the future, that aims to develop future leaders and future professionals within our field. And so these are great opportunities that would benefit yourself as an individual, as a professional, as a student, but also the profession as a whole. Now, what we'd like to do is take some time to answer some of the questions that have been coming in and have some discussions with our co-hosts and panelists. We're fortunate to have Francis Narek here, who's a part of these task force efforts, so he'll be able to give and fill in the gaps where Laura and myself may not be able to fully complete the picture. But we'll leave this slide up. If you're not a CEPA member, please go ahead and scan this code and look at your membership options. So now I'll ask Laura Newsom, our incoming president, to go through the list of questions that have been posed, and our panelists will do our best to answer those questions.
Thank you, Cemal. I have a question from Brian that says, there was an initial big push to get CEP signed up for an NPI, but I haven't seen anything recently. Since this is an important step, what is being done to increase these numbers?
Francis, you want me to answer, or you have?
Oh, I was wondering if that was for CEPA. For the NPI numbers, I think we're going to continue to push that as part of our communications. I think one of the big things with ACSM is to work more collaboratively together with CEPA. Part of it is just the stuff our certification board does is for occupational credentialing, and then the NPI number and kind of the advocacy of that. That is something that we're going to continue to push as part of our requirements for the QHP designation. I think it's helpful to have I guess a better understanding of why the rationale of what we're looking for. I think one of them is when we're looking at the components in where we want to work in the healthcare space, we just have to use like to like terms and using it for specific purposes. So when we talk about certifications, that really is just the independent assessment of competency in the profession. So it's not scope of practice, it's competency. It's like, are you safe and effective enough as a clinical exercise physiologist? That gets tied to continuing competence standards. How do you remain competent over time, which is like how all national boards function. The third one is just like is registration, and making sure the registration functions exactly how other registrations work, for like registered nurses, dietitians, etc. They function exactly the same. So the whole purpose of that is to the stick of the profession. So if I have some sort of unethical behavior, how do you remove them from the profession? And all of those guys ties together is to identify, especially to healthcare, who is qualified to deliver the services in clinical exercise. How were you educated? How were you independently assessed? How do you remain competent over time? And where do I find you? Those are the components that are there. The NPI number, the way we look at the NPI number within ACSM is right now, from the billing side, it isn't used for billing right now because the NPI numbers, there's two different types. The NPI numbers is for the facilities and the NPI numbers for the individual. Now for the NPI for the individual, the reason why we're using that and why we want to push for people to get the NPI numbers is to do a count of how many people are in the profession. Because if we have 30,000 people, is it 10,000 people, is it 400 people? How many are those practicing in the field today? And where are they located and where can you find them? That's the reason why we want it. And we're continuing to push that, continue to push that as well. Why we haven't done that yet is we don't have enough hands on deck to be honest. I think a lot of it's just doing the occupational research that really needed to happen in the first place. What do clinical exercise physiologists do in practice? And how does it get tied to kind of the efficacious things beyond just cardiac rehab? So we spent a lot of time doing more of the occupational research, but we're going to continue to push that as we approach CMS and the AMAs. Is to go, these are the individuals that have NPI numbers. Here's where they are. Tie that to occupational credentialing codes. And then the last part is just continuing to work with CEPA to push out that message as well to our clinical exercise physiologists. But we still need to do work on that, to Brian.
No, thanks. So just to kind of go off, that's a great question, Brian. You're going to see more and more of the MPI. We have another MPI question in the chat asking if we are practicing under a physician, should we get an MPI? And the answer is yes. Perfect. Yes. So how we qualify under that taxonomy number, again, either the EP or the CEP, if you're working in practice in a hospital, in a facility under a physician, you qualify. So you'll be able to follow the steps. They're pretty simple. You're going to end up, I think you have to put in your own social number, your information, but also the provider information as well that you're under. So yes, if you're practicing under a physician, definitely please go through and get that MPI. I have another question that I think, Francis, you're going to be great for, but any of us probably can help. But the question is, what are the best methods to convince administrators, so this is academic administrators, that programs should become accredited?
Oh, man. That is probably the biggest question that I get all the time. And usually it's phrased in one of two ways. That's one. The second one is, why are barbers or hairdressers licensed and clinical exercise physiologists not? That is probably the most common question that I get. And the big thing is, if you look at any of the kind of like the recent licensed professions, you look at athletic training, you look at physical therapy in most recent years, you look at dietetics, there's a specific process that you have to go through. And so even if you look at it, if you look at somebody who cuts hair, if you go to Paul Mitchell's school of cutting hair, you have to go through the process of actually, how do you learn how to do the profession, right? And then you're independently assessed by the state or whatever national board. And then you're going, okay, yes, regardless of school that they went to that prepared them for the job, we are independently assessing them whether they can do, are they safe and effective, and then they're licensed. In the space where when we're talking about the profession of clinical exercise physiologists, it is imperative that when somebody goes through and becomes a clinical exercise physiologist, that they're trained similarly across institution to institution to institution. The way it is now, exercise science programs across the United States, whether it says clinical or not in the title, teach whatever they want. That is a fact. So it is very difficult when we make the argument to AMA and CMS that those who are entering the workforce as clinical exercise physiologists are trained similarly. Without the programmatic accreditation, without having that, and institutions are teaching whatever they want, you're going to be a second-class citizen all across the board, because you don't function the way other organizations do it, right? So whether it's dietetics, athletic training, anything else, how did you prepare the same way as they did? And one of the key things when you look at that is, when you look at the RCEP and the CEP before, you had multiple certifications, going multiple pathways. The pass rates for those programs are around 28 to 32% pass rates. When you look at similar adjacent health occupations, dietetics, NCLEX, which is for nursing, et cetera, the pass rates are between 80 and 90% pass rates, because the schools prepare them to do the job. They get them the experience that they need to have to do the job successfully and safely. But when you talk about exercise science, every program teaches it differently. If you do not get the programmatic accreditation, you're not going to be treated as, you're not going to be considered an equivalent in healthcare. Full stop. You're not. And until you get that, until we have enough uptake from universities that see that, and you want to be treated like physical therapy, you want to be treated like nursing, then you have to go through the same process. And if you don't, you're not going to be treated as equals. And until that happens, what's going to happen is that healthcare administrators are going to treat clinical exercise physiologists as if you're all personal trainers. You went to school with your exercise science degree, you got your master's degree for a reason. And when we're doing this and we're competing with the AMA and we're talking about like these are qualified professionals, we have to show that our clinical exercise physiologists, when they graduate from these programs, are trained in a way that physical therapists aren't or nurses aren't. When you talk about physical therapists who are working in clinical exercise physiology, how did they learn how to do all the exercise testing and prescription that you guys all have done? And the answer is they haven't. Same thing with nurses, same thing with the rest. So we have to have enough adoption by universities to get people prepared for the workforce. Otherwise, you're not going to get there. I hope I get really passionate about this, Laura, but certainly I think I'd love to have what your thoughts are on that as well.
It was a perfect question for you, Francis. Go for it, Cemal.
Yeah, I wholeheartedly agree with Francis, his explanation and the rationale for it. I'll take a different approach to add on to that and the reasons why programs should become accredited. So let's talk about incentives for that program. I know a number of individuals, number of professionals coming from clinical exercise physiology programs who are faculty on these CEP programs. And a number of them have expressed that they're having a difficult time filling their master's classes, recruiting individuals to be students within their master's program. And so when we're looking at incentives to move towards programmatic accreditation, 2027 is coming. In order to sit for an ACSM-CEP exam, students have to come from an accredited program. So now let's fast forward to 2027, and you are a part of an established program who pumps out phenomenal CEPs, and they get jobs, and you may be asking yourself, well, if we're doing fine, why do I have to go towards programmatic accreditation? This is going to be one reason, because individuals or students looking to become clinical exercise physiologists will look for accredited programs. So if you want to remain competitive, if you want to get the best students in your program, the reality of the situation is that it's going to benefit you to move towards programmatic accreditation. Now, if you do the internal review of your program, as Laura had referenced within the slides, and you realize that we really don't have any student graduating to go towards clinical exercise physiology or applied field, and you're doing pure research, then yeah, maybe programmatic accreditation doesn't apply to you. But if you have a good proportion of students that go through your program specifically to work in applied settings, this is going to be extremely meaningful to be able to grow the profession, have students go through your program, and become accredited and individuals and QHPs. So this is one thing that is coming down the pipeline. Francis.
One other thing is when we're looking at, and I think folks just get hung up on the accreditation part. There's a couple parts of it. There's the accreditation, you're looking at accreditation of universities and the accreditation of programs. And the emphasis on programs is I think pretty evident here, but you always hear regional accreditation from before. Regional accreditation is accreditation or third-party accreditation of a university. And so regardless of major you go into, the university can support you. So if I'm at University of Michigan, I changed my major 15 times, the university can support me regardless of major that you go into. Programmatic accreditation is if I go into an exercise science program, how does that program specifically train me for a job at the end of it? How does that program in exercise science prepare me for a job as a clinical exercise physiologist? That is the evidence that we have to provide to healthcare of why our clinical exercise physiologists are uniquely qualified to work in healthcare. That's what we point to. And frankly, as we continue to work with AMA, that is a question that always comes up. Mm-hmm. So I think that's one of the big things. The other is what we hear from employers and why programmatic accreditation is extremely important is what we hear from employers is that students who graduate from exercise science programs are book smart, but they're not work ready. So that is a thing that we hear from employers across the board. So that they are unable to start working day one, that we have to kind of reteach them actually how to work in the workforce. That is really the reason why the programmatic accreditation for our certification board became very important for us, because not only are you safe and effective for the clients, but you're meeting the expectations of employers. It was a huge key as well.
No, it was a great question. I'm glad we got it because we know it is really common. The only other question I had was, wanting the article. I put that in the chat. Anyone who's looking to follow the step for the MPI, I threw that article in there. we're open to any other questions. If anyone has any, this is the time. We're here to help.
There was a follow-up question. One was, how does this apply? So we're talking about accreditation. How does this apply to those of us who have already graduated grad school? So you can sit for the CEP exam. You can get that certification, become board certified. So that doesn't directly impact you. And inevitably, Francis, you can talk to more details, but whenever we're making these large transitions, or professions have made these large transitions, there have been periods of transition, grandfathering periods, or time given to individuals to be able to accumulate the experiences or knowledge to fulfill the requirements of the new requirements. So as it stands right now, if you've already graduated from grad school, you can sit for the CEP exam. Everything is moving as is. So no major changes. It's 2027 when that becomes implemented.
Yeah, the only that requirement of having to graduate from a COAES or COAES program is only for those who are graduating on or after August of 2027. So those who graduate before then, it doesn't apply to you.
So another incentive for graduate programs and programs to apply for accreditation before 2027 is to ensure that classes that are rolling through and will be graduating on that date are coming from accredited programs.
I have another great question. This is a really good one. So I'm going to share. It says, from talking with colleagues and learning more from CEPA and other organizations, I'm fearful that COVID and lack of recognition, along with poor salaries, have driven CEPs out of our profession over the past few years. Do any of us have any concerns about the scarcity of qualified CEPs in our field now and in the future?
I'm actually on the opposite side of that. COVID has actually been beneficial for CEPs. The reason why I'm saying that there's two things that are coming down the pipe. One is from COVID is that there is a healthcare shortage across the board for everybody. So nurses who have a very wide license are now being asked to rejoin and pulling them out of programs like cardiac rehab. These clinical exercise physiologists are delivering similar, if not equal, patient outcomes as nurses. So it drives more opportunities for clinical exercise physiologists into cardiac rehab or pulmonary rehab and kind of related fields. I think that's one. The second one is remote patient monitoring is the other field that's coming down as well. So that's the field, I think, with the clinical exercise physiologist not only being in person, but being able to practice in a virtual sense is coming down the pipe as well. So it's going to provide a lot more opportunities for CEPs. But now the question is well, what do you do and how did you train to actually be knowledgeable enough to do that? That's going to be that's the part where we have to go back to, is that these are how the individual are uniquely trained.
No, I think that's a great response. I do agree that there are CEPs who do leave the field. Many who do end up going back to school and taking on large debt for other pre-professional programs to not earn much more money. So I think, I recognize that this happens. So I've met a lot of people who've done the same, but I would agree with Francis, working a little bit, as we've mentioned on the other town hall, the Million Hearts initiatives with cardiac rehab, they are really in need of workforce, CEPs entering the workforce, because there's really a scarcity of healthcare nurses, specifically nurses. So there are people who leave, but I really do think there's only momentum for more and more CEPs to be hireable.
And I think the part about it, I think you skipping to the chase, I think for a lot of the folks is just we're not getting paid enough. That's why we're exiting. I mean, I think that's very clear, but I think there's ways that when I've done my listening tour around the regional conferences, you hear that all the time. And in fact, that's a great point, but there's a couple of things. One of them is that, how do you credential stack to be more employable as a clinical exercise physiologist? Are you becoming a certified diabetes educator? Are you becoming a health coach? What are you doing to add on to the kind of extending your ability to practice through your certifications? One, the other one's potentially going and getting your MBA or getting your PhD. Those are ways to advance yourself in your career. I think that's one of the things that's there. But because the education and the requirement for certifications by employers to be a clinical exercise physiologist is all over the map, healthcare administrators don't know even who the heck we are. So being able to go consistency across the board of training, certifications, et cetera, nomenclature of names, because if you think about it, back in 2017, you had an exercise physiologist, a clinical exercise physiologist, a registered clinical exercise physiologist, and then you had a kind of a registry, but not really. But then the degrees you could get it. You don't have to really get accredited. So just like to explain that to a healthcare administrator, it was just like you're jumping through hoops after hoops to even explain what you are. They're just like, I don't know who you are, but I guess I'll just use nurse. So that's one of the things is just like when you're trying to tie these together, then you can talk about the nuance or the differences between, well, how are they qualified to deliver that? When we can start pushing back and start fighting for the CEPs to healthcare, it's just like, well, why can somebody who's a nurse who has just a bachelor's degree get paid 2 to 3 times the amount of a clinical exercise physiologist that has a master's degree that was specifically trained to do this, and they get equivalent outcomes? That's where you really need to push. But until we have that evidence, there's really nothing we can say. So, I mean, that's the reason why from the occupational credentialing things, you just have to talk off the same playbook.
Jamal, you have a participant with their hand up.
Let's see. Let's go ahead and let me see if I can provide privileges here. While we work on that, Laura Newsom, any other questions that came up that seem like good discussion points?
I have one that just came in. So it says, given these conversations regarding CEPs receiving proper training, why are AEP accredited programs also eligible to sit for the CEP after the 2027 deadline? The JTAs and program requirements are different between the AEP and the CEP. Should the push be for CEP accreditation only?
So are we talking about the AEP exercise physiology accreditation for that program? Can you explain that a little bit further?
Yeah, that's all it's in the chat.
So for the CEP and EP, they have to meet at least the standard of the COA's accreditation or equivalent. That's the stipulation. Now, the equivalent would be a program like the one with ESSA in Australia. So in Australia, they have to be at least meet the standards of preparing them specifically for the job as an exercise physiologist.
I just got clarification. So I think to help us, we're looking at the applied at the master's level.
Oh.
So looking at, thank you for clarifying. So looking at the two different masters, the applied versus the clinical.
Yeah, that's something that we're looking into as a board. I also sit on the board for the COAES. The applied versus the clinical, it really should just be the clinical. I will take that and bring that to our board as well, because it really should be job role, but not like, because if it's right now when you're looking at it's accredited in exercise science, there's not a job for exercise scientist. It's a job for an exercise physiologist, or it's a job as a strength conditioning or personal fitness training. They're like specific job tracks that you go down.
Yes.
So that's a great point. You can argue, if you look at the applied one, if an organization in fitness decided to do a certification in, say, data science in exercise, then you can go, maybe that's the applied one, because that would track more towards a PhD track. I would say that's more applied than clinical.
The individual who had their hand up may have been a mistake.
I don't see them anymore.
Yeah, mistaken hand raise. So any other questions that came up that we wanted to address?
I have nothing on my end, Jamal.
All right. This has been a great conversation, and we have a list of these communications in our chat that we'll be able to again go through, and then be able to provide some of the script and some of our answers to those that we may not have been able to have a chance to fully answer. But thank you once again, everyone, for taking time. Oh, Francis, yes.
Sorry, Jamal, but I wanted to promote the CEPA conference that's coming up. Graham, Melstrand, myself, Brian Biagioli from the US reps are going to be on there to answer your questions as well. We're going to be talking about, and you're going to be hearing about this a lot, is the National Exercise Referral Framework. This is a massive change of strategy, both from ACSM, the Coalition for the Registration of Exercise Professionals, our group with the Physical Activity Alliance is really going to start pushing for this national exercise referral framework. We're doing the first topic on it at CEPA. And so this is an ability for you all to understand the direction of where we're going for the next 5 to 10 years as organizations, and CEPA is the tip of the spear for our exercise professionals. And so that's where we're pushing real darn hard at ACSM, and with working in collaboration with CEPA and our advocacy efforts with the Physical Activity Alliance, the U.S. Registry, the Coalition for the Registration of Exercise Professionals, and the Committee on Accreditation for Exercise Science. So it is an industry initiative that we're pushing. So it's not, the CEPs are the tip of the spear, and that's where we're headed. And I would invite all of you to join that conversation and ask tough questions. I mean, that's what I tell Cemal, Laura, and others. It's just like, as staff members here at ACSM, we expect you to hold our feet to the fire when we're pushing these initiatives forward. And the reason why we're doing this is on your behalf and fighting for the profession. And that's my job, and I am super passionate about it. And I look forward to working with you all coming up.
Yeah. Thank you so much, Francis. I mean, this is truly a very exciting time within our profession, and it's largely due to efforts of our members, of our individuals, professionals, but just the organized work that the task force and everyone involved in the subcommittees have been putting forth. And this is going to be another major part of our professional history. So I'm looking forward to seeing what the future holds for us. So again, thank you everyone for your attendance, your questions. If you have any additional questions, please go to our website and contact us directly, and we'd be happy to answer anything that comes our way. And thank you again for Laura Newsom, Laura Richardson, Francis for being on the call, and looking forward to moving forward as an organization. Have a great evening, everyone.
Thanks.